right, our next speaker is Dr. Gopi Shah. She's a staff cardiologist here and amazing cardiologist and imager. And I know we touched upon transesophageal, but I think she'll take it to a different level. And when should I request a transesophageal echocardiogram? Gopi?
Welcome to this conference, and thank you for being here. I'm going to try and make this as interesting as possible and take it from the level of sophistication of the CT and MRI back to the good old-fashioned ultrasound. So before understanding when TE should be used, it is important to understand what does TE offer. In other words, what is the advantage of TE over, say, echocardiogram or other modalities that are available to us, the CT and the MR. So I would like to start by the very basic. The esophagus is right here, that pink thing going here, and this is the view from the back, from the esophagus looking in the front. That's your heart. And you can see the proximity of the basal cardiac structures to the esophagus very well, including the aorta. And therefore, this makes esophagus a very ideally placed organ to put your probe down and to take images of the heart. You get excellent resolution. We can use high-frequency transducers. And there's been significant advance made in technology of TE too. It was first became available in the 1970s. It was initially just monoplane. You could just go in and out. Then it became biplane, so you could view it in two views at two angles. And then in the 1990s, we got the multiplane modality of imaging for TE. And of course, the latest kid on the block is the real-time 3D imaging, which makes this technology absolutely essential for intra-procedural imaging that has now become very common. So as I mentioned, we have a lot of views how we move. We move craniocaudal. We have orthogonal planes. Now this is multiplane, so you can go from 0 to 180 degrees. And then you have flexion probe. You can antiflex, retroflex, and you can, of course, swing the probe right and left. And this is a schematic diagram showing how the probe sitting here takes different planar views of the heart and how detailed images we can get. I want to spend a little more time on this because this is one of the most important uses of the TE for evaluation of valves, in particular endocarditis and in particular prosthetic valves. So you have your TE probe here, and as you can see, the mitral and the aortic are very in close proximity, and the visualization is excellent. Less so for the pulmonary, and of course tricuspid is also very well visualized. And the last slide, schematic slide here, shows the close proximity of the descending aorta and the arch to the esophagus, and barring a small region which is obscured by the trachea and the bronchus, we can pretty much evaluate the entire aorta in TE. This makes it a very ideal tool for evaluating aortic dissection in patients who may not be stable enough to go for a CT scan, and we want to do it quick bedside. Of course, I forgot to mention that the biggest advantage of TE is that it is portable. We can do it bedside, and of course, we can do it in cath labs, holding areas, and in our designated suite. So what are the most common indications for TEE? In our own lab, in an annual year, we do about 5% of our imaging studies for echo are TEEs, of which the top diagnosis is atrial fibrillation, endocarditis, and valvular disease, and now increasingly intraprocedural TEEs. When I say intraprocedural, what do I mean? You have heard of mitral valve clip, Watchman device occluders. This is where the TE is also used very commonly. Obviously, it is also used in patients who are poor images and in critical conditions where the transthoracic images is not very good. And as I mentioned, cardiac masses, we have better imaging modalities, but still TE and echo both have a role. I won't go into this. Let's go on. We know the contraindication. I'm going to focus on the cardiac source of embolism, including atrial fibrillation. So I want you to first look at these images. Images say 1,000 words. This is an left atrial appendage. You cannot rarely see this appendage well on transthoracic. You can see in the first clip here, it's a normal, it's very clean echolucent structure. You can see the pectinate muscles. In this, you're seeing a little bit of haze, and that is the spontaneous echo contrast showing that there may be a lot of stasis going on, and you may want to be cautious before cardioverting this patient. And this, of course, nobody would cardiovert because there is a frank thrombus sitting here in the appendage. This is your mitral valve. So TE is extraordinarily sensitive and specific in detection of left atrial thrombus. This remains one of the most common indications for TEs in our lab. Again, a patient comes in, we get this consult request for TEs from neurologists very often. Rule out cardiac source of embolus. As you can see, we look at the appendage, we do the saline contrast, and I'll try and play this image again. Sorry, I skipped that. And you can see bubbles crossing over here. And then in the same patient, when we were looking at the aorta, the descending thoracic aorta and the arch, you can see significant atherosclerotic plaque, even mobile debris. This is at the level of the arch. And so you have to make a clinical diagnosis here, whether it was the small PFO, this was an elderly patient, 84-year-old. Most likely it's the atheroma that's causing and not the PFO, which probably has had it since his birth. So again, significance of this. I mentioned this. This was a very interesting case. A 62-year-old gentleman comes in with chest pain. He is hemodynamically unstable. EKG shows ST changes. And he was in rapid AFib and unstable, so they were debating whether to cardiovert him, but they didn't know how long he had been in AFib, so a T probe was dropped, and sure enough, a T probe was dropped, and you can see here, if I can move this mouse, okay, play. A clot. What was interesting is I want you to pay attention here in the second image. You see a little clot sitting here. That's your right coronary cusp. Very nice here. That's your left, that's your non, and that's your right. And the next image shows a beautiful inferior wall MI. So again, cool things that we get to see on TE, and that's not to be missed. Moving on to endocarditis. Endocarditis is, again, one of the most common reasons why we do the TE. The transthoracic echo sensitivity in PKM endocarditis varies significantly from center to center. It has been reported in the range of 28 to 63%. TE is much more sensitive at 86 to 98%. Both are very specific. That means once you see a vegetation on the valve, you know you have an endocarditis. One thing which I want to emphasize is the negative predictive value of a normal TE or a transthoracic echo. Both of these have a great negative predictive value. On a transthoracic echo, if you have good quality images, you don't have any prosthetic valves, you don't have any leads, and you have decent images, and it is normal, then the chances you have endocarditis is pretty low. So the negative predictive value of a transthoracic is as high as 98 to 100%. This was a very elegant paper that was done by Dr. Zoghbi way back in '94. For prosthetic valve, however, the negative predictive value for a normal TEs is still only 90%. And that emphasizes that even on TE, with hardware that's present, you can sometimes meet very early endocarditis. And therefore, clinically, it is important that if you have a bacteremic patient, you have done a transthoracic and a TE, and you don't see a vegetation, but your clinical suspicion is high, it behooves you to go back and do another TE on a person with a prosthetic valve. So I'm going to start with native endocarditis, and I hope my images play well. And they don't want to play. Okay, I'm going to pause it. Okay, you see this vegetation here, that's your anterior mitral leaflet. You see it's how bulky it is. And for people like us who read in the lab often, that's a no-brainer, that's a vegetation. We put in some color to see how bad is the integrity of the mitral valve interrupted. And you see some color here in these images. I want you to focus on this, which is, again, you see beautiful bulky vegetation on the anterior leaflet of the mitral valve. And you're seeing hardly any color here for MR. I want you to look at this. This is something that we do. We do a Doppler across the mitral valve to see if there's any regurgitation, and you see this very V-shaped jet. For an experienced reader, this is a concern that you have a wide open mitral regurgitation, which you're not picking up much by color because there is rapid equalization of pressure. This is the TE on the same patient, and you can see this beautiful bulky vegetation. And I want you to see this image, and you can see a lot of wide open severe MR. So again, the importance of TE. You can underestimate and miss jets on transthoracic, which you would pick up on TE. This is native valve, mitral valve endocarditis. This patient directly went for TE because fulminant bacteremia, new murmur, looking toxic. And you can see beautiful endocarditis on the anterior and posterior mitral valve. Posterior leaflet actually is flail and prolapsing back. Again, significant regurgitation on this image here that you can see. Again, these are the different views. Again, I'm showing this to show how orthogonal views we take to determine which scallops are prolapsing. Again, this shows that the P2 is completely flail. Actually, the whole entire posterior leaflet is flail. And here there is a suspicion of a small hole in the anterior leaflet. And this is a beautiful 3D image. And I'm going to show you the hole here in the anterior mitral leaflet. This is the hole here. And this is the posterior leaflet that's prolapsing back. So again, beautiful images and data available on TE. Prosthetic valves are notoriously hard to image on transthoracic because there is a lot of acoustic artifacts or reverberation artifacts. And this is a gentleman who has had he has had a prosthetic aortic valve, and you know it's prosthetic because you see a lot of thickening in this area. Again, you're looking at it in different views. This is the only view on transthoracic where you feel, okay, there could be a problem in this aortic valve because you see a bulky vegetation or what looks like bulkiness in the subaortic area. This is a T, and you can see how beautifully compared to the transthoracic, the visualization of the valve is, the leaflets is, and more importantly, the peri-aortic area. You can see here there is an aortic abscess developing. This is a very thickened valve with vegetation, again an aortic valve, para-aortic abscess, beautifully again seen on 3D. So real-time 3D is adding a lot to us in terms of capacity to image because you can now see it in 3 dimension. Prosthetic, so there's other several cases of prosthetic valve endocarditis. This was a person who underwent double valve replacement, both mitral and aortic. And what is interesting here is very early on, he was shown to have some thickening in this para-aortic area. He was febrile, malaise. They started him on antibiotic treatment. Again, I want you to pay attention to this thickness here in the para-aortic area. He was brought back in for imaging a month later, and he was found to have an aortic abscess. How we define abscess is by looking at this echolucent area around the aorta. And again, he underwent a redo and beautiful results, intact valve and intact integrity of the valve here. I'm going to go back to, so again, prosthetic valve stenosis is also very nicely picked up on TEs. This is a patient who was short of breath, had a history of mechanical valve. You can see the 2 leaflets of the mechanical valve, and you get a sense that one of the mechanical valve leaflet is not moving well. You see some echo densities here on the top. Sorry, that went fast. And there is actually vegetations here. And then you can see the gradients are high. This is the Doppler that shows how high is the gradient across the mitral valve when it was about 13. So this is a person who had either a vegetation or thrombus obstructing the leaflet movement. Is it time? Oh, Lord. Okay.
That's okay. There's a question and answer.
One last slide,
We have
Doctor.
excited speakers this morning. We have
Okay,
exciting speakers this morning.
You know, I am so sorry for but the one thing which I wanted to show was a picture is worth 1,000 words, and I just wanted to show one image. This is the aorta that's very aneurysmal, and we can look at the beautiful flaps here that you can see. And TE has a great role in picking up dissection flap. That's a dissection flap. That's a dissection flap there. And you put color and you can see the lumen. Again, sensitivity, specificity very high. Won't go into cardiac masses or ASDs, which are also very well visualized. I apologize for not completing the talk, and thank you very much.
You did a great job.